Oh, okay. So this portion of the presentation will focus on the safety and side effects of blood flow restriction training. Okay, so there'll be three topics that we'll cover. It'll be systematic reviews and what the literature currently tells us about the safety of blood flow restriction training in the presence of exercise or without, the proposed screening process, as well as a study example.
Okay, so I start off by looking at a very large study that looks at Katsu training, which is essentially the Japanese form of BFR, and that has been around for the last 5 decades, and so they have much larger epidemiological and pooled data. So Yasuda in 2017 looked at 232 clinics in Japan, over almost 13,000 subjects. And then you can see that there's actually more females than males within this. However, we're now looking at the side effects and the most common side effects that were otherwise seen. So everything from cool feeling, numbness, subcutaneous hemorrhaging, where someone will actually gently bruise under the cuff. This can be also mitigated by gradually exposing their body to the BFR in the gradual increase in pressures over subsequent settings. Other things include pain, nausea, itching, hypertension was relatively low. One of the more common ones was anemia, where they would experience some of the same side effects there, headache, and others. Okay, so this was a separate study that looked at 3,500 different subjects between 2007 and 2013. Like that previous study, it was conducted in Japan, as there's much more data that has been out there. And this is the adverse events that they did find when using Katsu training. They did not specify as far as the screening that was done on these individuals. So the first is really unfortunate. A brain hemorrhaging did occur, comparable to sudden. The authors compared it to sudden cardiac death during an athletic participation. 35 years old, hypertrophic cardiomyopathy, cardiomegaly, coronary artery malformation, aortic rupture, brain hemorrhaging. These are all risks of physical exercise in general. However, they were not. It was unable to make the conclusion as to whether it was the BFR that actually, or the Katsu training that actually caused it, or whether this was simply, again, the sudden cardiac or brain hemorrhaging that may have otherwise occurred. However, obviously there is a risk there, and if you take this study as well as the one previously presented just on the last slide, you can say that I guess brain hemorrhaging would be like 1 in 20,000 or so. However, we don't have any of the background data as far as whether this person was appropriate for Katsu training or blood flow restriction training, and nor do we know whether this individual would have already had this event in the absence of the BFR. Okay, so venous thrombosis. So BFR actually induces a fibrinolytic state, aids in the restriction of thrombus in formation, meaning that it's actually somewhat beneficial, despite that you get the venous pooling that occurs within the limb. And then transient numbness. Again, the number reported was not specified. Rhabdomyolysis did occur in one individual. This is unfortunately. I don't quite understand the mechanisms here, because rhabdomyolysis is, as you may or may not know, is an excessive breakdown of muscle tissue and the effects that otherwise has on the kidneys, and it is a medical emergency. However, with blood flow restriction training, because there's actually with gradual exposure, there's less DOMS. There's actually less muscle tissue breakdown, which makes one of the reasons why BFR is really advantageous within an athletic season or prior to an athletic event, to prevent conditioning or detraining, while still maintaining and sustaining the strength gains and hypertrophy that someone has. However, rhabdomyolysis, given the high volume of the exercise, and it wasn't specified whether they were using the recommended 20 to 30% of the 1RM or what have you, but it did occur. Venous injury and induration also has occurred, number not reported. Usually those people are most at risk, females 30 to 50 years of age, spontaneous resolution within 1 or 2 months, repeated pressurization and depressurization to get like prior to doing the cuffs with exercise is recommended to allow the vessels to become accustomed to the additional pressures. And again, adhering to the KAATSU training time or blood flow restriction time is similar, 15-20 minutes, no more than 30, would be highly recommended to avoid the venous injury and induration. Okay, so now looking within the states in actual blood flow restriction training versus going under the name of KAATSU training, we find that there were 3 individuals that was found in this case report that they highlighted as far as the effects. So scientific data indicates that the overall safety of VFR, at least in the healthy young population, is safe. Caution is thus needed in the application of BFR, and gentle familiarization with the training, as alluded to in the previous slide with the venous induration and potential injury, is recommended so that the venous and the vascular system can actually become accustomed to the pressures. So there have been a number of reviews that have looked at the safety of blood flow restriction training and its effects, side effects, and what populations are indicated versus contraindicated versus precautions. So we're going to step through some of these systems.
So to date, there have been a number of systematic reviews and meta-analyses that have been conducted in the research to try and look at the safety of the hemodynamics, considering the contraindications and precautions of BFR and what populations may be more at risk than others. And so we'll take over the coming slides, we'll take a look at a couple of these reviews. The first systematic review that we'll consider is Domingos et al. In 2018. It was one of the largest systematic reviews and meta-analyses conducted to date, and it looks at blood pressure with and without BFR in the presence of exercise.
They looked at the effect of blood pressure during resistance training of greater than 60% 1 RM. And you can see that there was the control versus the BFR, that the diastolic blood pressure did increase significantly more than that of the control. Same thing with the effect size during resistance training less than 1% 1 RM. Systolic blood pressure dropped and diastolic dropped more than the controls thereafter. So yes, you may have a slight increase in the systolic and the diastolic during the exercise. However, this actually, your body in a healthy individual responds to that by actually decreasing your resting blood pressure thereafter, which can be somewhat advantageous. These time points are actually taken an hour after the exercise. It can be advantageous from the standpoint that if your goal is to gradually reduce the overall blood pressure, that there is an aggregate and long-term outcome on this, or a long-term effect, I should say. Okay, so here are the conclusions of the study. BFR at greater than 60% 1 RM will result in increased diastolic blood pressure versus traditional resistance training. BFR less than 60% 1 RM will increase both the systolic as well as the diastolic versus traditional resistance training. And BFR will result in greater systolic and diastolic decrease in hypertension and healthy blood pressure patients 60 minutes post-exercise versus your traditional resistance training. Thus, the authors go on to say that it can actually be used as a potential modality if done in the right individual with proper screening, that you can reduce. Okay, and then finally, here's a quote from the conclusion. Resistance exercise with BFR should be prescribed with caution, especially with BP control during exercise is required and is necessary. Okay, looking at a recent study in 2019, effects of blood flow restriction exercise on hemostasis. So when we're actually looking at, I had alluded to in a couple slides before, how that blood flow restriction training can actually have a fibroinolytic effect. So this is an example of that. And so we're going to look at, or I guess not an example of that, but this is when you actually look at a systematic review of that, of the results of that. So a couple couple of the blood factors that are used in these studies or that are looked at. You have tissue plasminogen activation, or TPA, fibrinogen, FDP, prothrombin time, and D-dimer. You can see the definitions of each of them shown there in the middle column. I'll let you review each of those. And then you have the normal ranges shown there in the final column. Okay, and then here is the short-term conclusions that were made. Intervention of blood flow restriction exercise increased the fibrinolytic activity assessed by TPA measures. The data effectively supported the safety of BFR implementation for young, middle-aged, with stable ischemic heart disease individuals or apparently healthy older adults. Okay, let's look at the long-term conclusions that were made. No long-standing significant effects indicating that blood clotting function remained unchanged in healthy subjects. Findings were supported in another investigating report that no adverse effects of BFR with low load resistance training, BFR with elastic bands, on FDP or D-dimer in older healthy adults. Okay, another systematic review here that looked at the hemodynamics. So 21 articles included. You have 16 articles that looked at blood pressure, 19 that looked at heart rate, rate of perceived exertion was included in 4. And this is a systematic review here. Hemodynamic changes, heart rate, systolic, diastolic, mean blood pressure, and RPP promoted by low intensity resistance training do not seem to differ between the ages and the body segments. So it doesn't matter how old they are, and doesn't matter if you include the upper or the lower extremities with the blood flow restriction. The hemodynamics are relatively the same. Okay, the changes are within normal limits, however. Furthermore, the low-intensity BFR may be considered safe and viable for special populations, such as the elderly and cardiac patients, among others, because it promotes strength and hypertrophy without negatively changing the hemodynamic measures.
Okay, so here are 2 review articles that have called into question the safety of blood flow restriction training for similar reasons, as they are concerned about the high mechanical peripheral tension and the afferent stimulus that this has on the autonomic nervous system, and how this may lead to elevated blood pressure, not only locally but also systemically. And so we'll take a look at this reflex and this mechanism next. All right, so this is a layout and a schematic of the exercise pressor reflex. The reflex and the mechanism that the previous 2 authors were primarily concerned about. So it's a relatively busy slide. I'm going to step through it in a manner that makes it relatively simple and hopefully understandable. So there's 3 influences that affect what happens not only to your heart rate, the cardiac output, but particularly the blood pressure under the presence of exertion and physical activity. So irrespective of BFR, this is how the system adapts to traditional resistance training. So the first, you have the central command, which are more the efferents that come from the brain and not only recruit the motor units of the physically active muscle, but they also influence the brain stem and the cardiovascular control centers that exist there. And then this is integrated with the 2 afferent peripheral information that is coming, 1 from the muscle, 2 from the large carotid and aortic arteries. So the second here, as you can see, is labeled EPR, or exercise pressor reflex, and this is sensed by the nervous system activity as well as the compression and the chemo response, the change in the blood around the active muscle due to the use of oxygen and the increase in metabolites and the increase of CO2. So the signal is sent from the muscle to the brainstem, and this is integrated with the similar afferents that come from the carotid as far as the amount of blood pressure as well as the chemistry makeup of the blood. And the three of these integrate at the brainstem that then influence the sympathetic nervous system. In the presence of physical activity or exertion, there's going to be an increase in sympathetic drive, which then leads to the increase in heart rate, increased cardiac output, increased contractility, and increased arterial blood pressure. Additionally, on the peripheral vascular system, there's an increase in arterial resistance and a decrease in venous capacity as the blood is shuttled to the active muscles and kind of shunted away from those areas of the body that are less important given the amount of physical exertion that's occurring.
So here, now in the presence of blood flow restriction training, the exercise pressor reflex, as well as the input from the central command center, is increased and augmented by the increase in metabolic demand that is occurring at the muscular level and the signals that are being sent from the afferents. And so this then would lead to an abnormal increase in the sympathetic nervous system drive as well as in the exercise pressor reflex, which is said to further augment the hemodynamics of the heart rate, cardiac output, contractility, etc., significantly more so than the normal exercise scenario. Now, this is more of a kind of a scoping review and opinion commentary paper, but their purpose in writing it is to, one, draw light to it because it has otherwise been fairly quiet within the blood flow restriction and CATSU training models.
So here are a couple of summary statements from Sprenger, 2015, the first author that called into question the exercise pressor reflex. Individuals with cardiovascular disease such as hypertension, heart failure, peripheral arterial disease are especially at risk for deleterious effects with cardiovascular events when performing BFR. Healthy individuals with resistance training in the absence of BFR are known to have exceedingly high systolic and diastolic pressures, over 300 millimeters of mercury. There's been studies that have demonstrated that at times these have even exceeded 400 and 300 millimeters of mercury, respectively, for the diastolic and systolic blood pressures. Sprenger states that there's going to be an increase in venous compression that leads to increased venous pressure that leads to increased valve damage and thus chronic venous insufficiency. Spikes in arterial pressure lead to increased risk of cardiac events. With the presence of BFR, it's said that these are going to be exceedingly higher, as demonstrated in the previous slide. Also, the authors make the argument that because of the pain response and the discomfort of the cuff, depending on the width and the amount of pressure that is utilized, that this can also increase the central command centers and thus augment the EPR, the exercise pressor reflex function, and thus leading to increased sympathetic tone as well as increased mean arterial pressure in healthy adults.
And so I think it should be important to note that arterial waveforms show that vascular changes appear to be localized within the musculature rather than systemic as proposed by Sprenger, and no negative effects on large vessel stiffness, augmentation index, and or aortic blood pressure have been shown. Correlations between the BFR-induced spikes in arterial pressure and risk of cardiovascular events is unknown. So again, it's more of a theoretical model that they are presenting. Further research is needed before BFR can be fully endorsed according to the author.
Another concern for BFR is the thought that it could potentially increase one's risk for DVT or peripheral blood clot. This article in 2019 out of JOSPT looks at that, particularly for those individuals that are coming off of surgery. Additionally, the authors go on to say that collective literature suggests that a proper prescription of BFR in the context of virtuous triad would not heighten the risk of developing DVT. And you may be asking, what is virtuous triad? So it looks like this. It's three primary factors that set the stage for potentially leading to a blood clot. So you have a hypercoagulable status, you have vascular wall injury, and you have circulatory status. So circulatory status is obviously altered given the fact that you're pooling blood in the extremity. Hypercoagulable status is one could argue is the recent surgery, and then the vascular wall injury, right? So they're exercising. So you can understand why someone might be concerned that all components of the triad may actually play a part in increasing one's risk. But what the research shows is that that's actually not the case, particularly when the individual is properly screened. Clinicians need to thoroughly screen for DVT or venous thromboses, signs and symptoms, and be cognizant of each patient's risk, irrespective of BFR. And so this goes into the proper screening and identifying which patients have higher precautions or contraindications than others.
All right, so Lenicky in 2011, this is just more of a conclusive statement when it comes to the summary of safety and side effects. So in their systematic review, in conclusion, the current research on BFR training with respect to safety outcomes confirms early reports that BFR exercise, when used in controlled environments by trained and experienced personnel, provides a safe training alternative for most individuals regardless of age and training status. So I think that again, as I mentioned, it succinctly puts together or concludes what the data has.
Okay, so that takes us through the systematic reviews. Next, we'll be focusing on how we go about screening proper patients for blood flow restriction training within the clinic.
Okay, so before we actually look at the proper screening process that is conducted in the States, let's again look back at what has been done in KATSU training over the last 50 years or so. So you have a pooling of 13,000 subjects, and these questionnaires were sent out to the different facilities. And so essentially these are what is recommended by KATSU training to be conducted prior to they're not all mandatory, but these are potential recommendations of things that can be done before the KATSU training takes place, right? And you can actually see that the checklist here, people gradually do the first couple really well, and then they kind of fade off, right? So they interview, they take blood pressure, hemodynamics, body weight, body composition they actually take, which is surprising, just given that it may not have a huge implication. You can get that really from their BMI as far as like stratifying the risk, and we'll talk more about that. These other things I was also quite I actually was questioning the fact that so few of these facilities took girth, and so few of them actually looked at or calculated the 1 RM, because we know that you need to be at if you're doing too high of an intensity with blood flow restriction training or KATSU training for that matter, that the hemodynamic response can actually increase to higher dangerous ranges. For instance, if you're pushing 80% of your 1 RM with restricted blood flow, that's when you're setting yourself up for failure and potentially a negative outcome. Additionally, the girth is usually recommended depending on the cuff that you're using. You can predict the proper pressure that would be put up to that, but they were taking the blood pressure. Perhaps they were doing it via Doppler. Okay, same studies. The only difference is now that they're asking these facilities whether they're doing this checklist, which is recommended for all subsequent trainings of KATSU training. And you can see that, again, they interview, they take the blood pressure, but only 75% of them do. Heart rate, pulse rate, again, gradually weaning off here, which is surprising and certainly not ideal. They're not only like 25% of them are actually taking RPE. Okay, so Scott et al. In 2014 came up with this decision tree or algorithm for utilization of BFR. I would have to say that I feel like the authors were somewhat biased towards BFR as we kind of follow this tree down, right? So we'll go through the questions. Does the individual have a contraindication for BFR? If yes, consult the physician before implementing the BFR. If BFR is approved, is the individual mobile? If no, apply moderate BFR. So if yes, then could the individual tolerate loads of 20 to 40%, 1 RM? If no, combine low workload cycling, walking, and exercise with BFR. If yes, combine low load resistance training. And then finally, the decision is, could the individual tolerate high load resistance training? That being said, that it is best to use high load resistance training in combination with low load BFR rather than just low BFR alone, right? So they do show some really. So at the end of the day, right, if they are contraindicated and the physician says no, then you shouldn't use BFR, and then otherwise you should be using BFR. The only exception to that is that you use BFR with in a combination with a high load resistance training program. So yeah, I'd say that there's a high chance of bias for this. And then this is really startling, actually, the frequency of testing. So these clinics were doing it once a week, and actually at the most once a month, which people see hemodynamics, right? They change on a daily basis, and so I would say that it would be highly recommended that prior to using BFR, if you so choose to do so or have access to it, that you actually screen properly with that subsequent training list that was shown, and I'll give you further guidance on that as well, at least on every training bout. And if they were only training once a month, well, we know the effects were probably going to be minimal, if at all, given the fact that it's optimized with 2 to 3 times per week for consistent 6, 8, 10 weeks. Okay, so Nakajima in 2011 came up with a couple of screening tools or recommendations. So intake information, symptoms, history of disorder, lifestyle disorders, family, etc. So really trying to stratify properly stratify risk assessment and demonstrating whether these individuals are contraindicated, there were precautions, or that they were free to use KATSU training. Additionally, here are the indications, precautions, and contraindications that have been recommended. You can see that the red asterisk there demonstrates for males greater than 40, females greater than 50 require exercise tolerance testing. Not unlike what the ACSM guidelines also recommend by stratifying people into indicated precautions, contraindications as far as stratifying risks. So high blood pressures, so according to Nakajima in 2011, they said that as long as you were within the indicated range, you were safe to use blood flow restriction training. I think they were a little bit liberal in my opinion as far as the precaution range. I don't know if I'd feel, actually I know for a fact I want to feel comfortable using BFR with someone whose systolic was 160 or higher, nor would their diastolic being above 90. Yeah, we'll talk more about how we can properly screen. I'm just showing you what has been proposed. Fasting blood glucose, again, it's a relatively high energy demanding, right? It's a metabolic stress that we're putting on these people. So we do want to make sure that if they are diabetic, they have sufficient stores of blood sugar to be able to perform the exercise in the modality safely. Hyperlipidemia, you can see there. Obesity, again, as I mentioned, that BMI is can be a precaution and even a contraindication if they do fall into that obese range. That it is not wise to be putting further restriction on the vascular system. Okay, so this was the otherwise point scale or criteria that Nakajima then took that information and succinctly created. So you have the points across the top, 1, 2, 3, 4, all the way up to 5. You have the criteria, you have the column score shown, and you have the total score. And so this is not really, this was modified from his paper, so I put it into a point. I kind of created it and succinctly put it into a single slide for you for your convenience. Should you want to use this point scale, this is the same point scale that is very similar to that is used within surgery when they're kind of stratifying people's risk of using tourniquets within surgery. So again, very similar criteria. I'm not going to go through all of it, but it's here for your reference should you want to pause the video and look through it.
Okay, and then our final section, specific study example. Okay, so this was one of the first studies that was done with BFR in the presence of hypertension, specifically done in women in 2011. So in the table to the left of the slide, you can see that in the first column are the method variables followed by the values. You have study design, subjects, duration, cuff of type, the type of exercise, the volume, and the intensity, as well as the tempo. So 18 females, 60 years of age or older with hypertension. So there was 3 sessions. Each session was randomized, so it was a crossover design. And it was randomized as far as which order they went in. So one of the options was control or no exercise, BFR 20%, 1 RM, or traditional strength 65%, 1 RM. The width of the cup that was utilized in the BFR instance was 90 millimeters or 9 centimeters. That's approximately 4 inches. Knee extension, so volume and intensity 3 times 10, 1 minute rest. BFR was done at 20%, 1 RM, and strength was done at your traditional 65% for your 10 RM. Tempo was standardized at 2 seconds up, 2 seconds down, 40 seconds per set, 4-minute sessions.
Actually show that BFR at 20% 1 RM is comparable to people with hypertension, actually doing resistance training at 65% 1 RM, which is the baseline minimum that you need, according to the research, to actually create a hypertrophy and strength effect. The diastolic blood pressure. So during resistance training, you can see that really a same effect here, where the BFR was really no statistically significantly different from the 65% 1 RM. Okay, cardiac output, same story. There was actually more stress on the cardiac on the heart for the over the 3 sets for the 65% 1 RM versus the BFR.
Okay, now for the conclusion, the summary, and the wrap-up.
Okay, so here are 12 basic principle foundations that should be used with blood flow restriction training. This comes from Nakajima 2011. We've already seen this study. So number 1, confirm no contraindications. Hemodynamically unstable patients should not partake in BFR. Thrombotic disease patients are contraindicated. Explain pedicle hemorrhaging risk, which essentially is the risk that you may get bruising underneath the cuff if the individual is not otherwise used to the training. And based off the presentation in the slide before, or slides above, you know that the individuals that are going to be at higher risk for this are going to be middle-aged females who are sedentary and or untrained. Individualize the training not only to the pressures but the loads that are used. Build relationships and trust with your patients. Pay attention for faintness, dizziness, and lightheadedness. Caution should be used in your older individuals as well as your post-operative patients. Always have an AED available when anyone is exercising. So this is not specific to BFR. Short-term and low-intensity loads are going to provide you the best and safest outcomes. Contraindications, the patient is sick, right? So if they already have a fever, right, it's questionable whether they should be doing exercise alone, not only just restricting their blood flow, right? If unsure about medical conditions, seek specialist consult. Okay, questions, comments, feedbacks, discussions. I know that's a lot of information. Please feel free to see the references below, as well as type any comments, questions, or concerns in the comment section below. Hope you enjoyed.